Hi everyone, and welcome to the latest episode of Notts Farmcast. We're delighted to welcome today Dr. Manik Arora. Manik has a very long title: Local Improvement Coach, National Neighbourhood Health Implementation Programme, NNHP for short, OIP for short. And he is also the chair of Nottingham City GP Alliance. So welcome, Manik, Dr. Manik Arora, and Mike Jones, as always, is here, our pharmacist, still a pharmacist, and our services implementation manager. And today we are going to be discussing neighbourhood health. And I think I need to start with a bit of an apology to contractors, because this has been a bit of a long time coming. And that's simply because we've not really had anything to say up until this point. And we were very pleased to welcome Manik to our most recent Community Pharmacy Nottinghamshire committee meeting, where he took the team and members through his sort of overview, really, of neighbourhood health, where he is at the moment. And it's a big job, as you can imagine, and there are no... I need to start from saying there's no straightforward answers at this precise moment in time. So this is just a bit of an overview discussion as to where we're at and maybe where we can see community pharmacy in the future. So I'm going to hand over to Manik first and just ask him about, just if he could quickly give us an overview of your role within neighbourhood health, Manik, alongside everything else that you do on a daily basis. Including sleeping sometimes for maybe an hour.
Thanks, Kirsten and Mike, for having me here today. I think along with being the local improvement coach, and as you said, and there at the GP Federation, and being a dad and being a husband and trying to still do the ferrying around as a taxi, life goes on in those scenarios. So I think within the, as you said, the National Neighbourhood Health Implementation Programme, the programme started September or last year, the autumn of last year. There are 43 sites across the country within the programme, and Nottingham City is one of them. Now, within the programme, we bring together colleagues from local authorities, social care. The secondary care colleagues are in terms of both the acute hospital, the physical health, as well as the mental health trusts, community providers, voluntary sector, housing, and general practice and community pharmacy. And all of that comes together into a melting pot to say, how do we make the care better together? And at the moment, if I have to look at neighbourhood health, I can look at it from two different angles. I can look at it from our services, which are all in different silos and we all do things differently. Or I can look at it from the person who's at the receiving end of the care. And I can go, I've got all these services in the community around me, in the neighborhood around me. I contact them regularly. I have continuity and relationship with all of them. How can we have that better coordinated?
Yes.
How can we have that better joined up? And neighborhood health is the care that I receive in the neighborhood around me. That can be from the voluntary sector, that can be from GPs, that can be from the community pharmacy, that can be from the audiologist to help my hearing, or that can be my care, that can be the social club that I go into, which helps me with my loneliness. So how do we bring that into the framework of where things do not feel as disjointed as sometimes do?
Yes.
And I would say that's the ethos within neighborhood health. I'm trying not to go into particularly what's the neighborhood health service, because nobody knows that yet. That's not been commissioned. That's not there.
Of course.
But when we imagine, so in our neighborhoods, there are two different aspects. There are formal services, but what we do, we sometimes learn more about the health condition that we have in the interactions in the social group that we have, rather than the 2 hours in a year that we spend with our clinician.
Yes.
20 different appointments because 5 minutes of here and there. So
Yes.
how do we bring that care closer in the community? Often, and one of the burning platforms I have to say on this one is, by trying to treat individual conditions only, where we have medicalized more and more things, we've got more individuals living with more number of medical problems, interacting with more number of systems, and nobody knows who to go to when they have a crisis because there are so many different touch points.
Yes.
How do we simplify the medicalized complexity that we have introduced? And we take away the agency of the individuals by actually scaring them what they're able to do and telling them that they can't do it.
Yes, absolutely. Absolutely. And you must hear that as a GP, Manik.
So it was so often when I used to hear that, you need to go and speak to the GP. And I would be saying, no, you actually have the information. How do I help you as a GP to allow you to make the decisions yourself? How do you...
Yes.
You don't need to medicalize those things. You don't... But we take away people's agency to be able to support them and make those choices themselves or make those decisions themselves.
Yeah. Okay. There we go, people. Complex, as I said from the start. Manik's underlined that. I don't know whether, and I know, well, I should have sort of said from the start, Mike has been our sort of community pharmacy representative in this area of neighbourhood health for some time, Mike, haven't you? I don't know whether there's anything you want to add there to what Manik's just said from your perspective. And I think it kind of maybe moves us on to talking to both of you about what role do you potentially see that community pharmacy can play? And it's a difficult question, isn't it? Because of everything that Manik's just said there. You know, where are we now? Where do we see ourselves? How can we, you know, what is the best way for pharmacies to get involved? Because we want people to be involved. I'll hand over to you guys because you're both the experts.
Sure. Well,
no pressure.
Just if I answer the first question, yes, I do have the privilege of working with this team of people who have been. I've got to say, the amount of work that's gone into making this work in City is just extraordinary, and
it's
you
huge,
know,
it
is, and it cannot be overstated. The work that has gone into this to make the change, to work within a national framework, but to make it come alive in City, and with the primary focus of a holistic care of a patient nearer to their home.
Yes.
And keeping them out of hospital.
Keeping them out of hospital, which is expensive. Yeah.
It is expensive. And what Manik brings is and it's a huge gift, and that is this sense of we've got this complex network going on at the moment. Call it silos. How do you simplify all of that? How do you describe that? How do you describe a vision of where you're going? And with always the intention of helping that a patient in a better way, just making it better for the patient. And so I just wanted to underline that. And I think what I see is all the focus at the minute, rightly so, is how do I set up a multidisciplinary team, as Manik's described, where you bring a number of professionals, clinicians, doesn't matter, people from local authority together, so that the patient, if you like, has a one-stop shop feel.
Yes. Yeah.
And they're being seen.
Yes.
They know they're being seen. They're aware they're seen, and they're aware that they can have answers to a number of things in one place. I think that's kind of amazing. But that's a significant challenge and a significant change from where the NHS is at the moment, and local authority actually. So it's one of the reasons we haven't said anything before, because all of that work has been going on and setting up, and at the moment we're trying to work out, so how can community pharmacy help?
Yes. Yeah. Where do we fit? Yeah.
Yes.
Yeah.
And I think at the same time, Mike, I'll take a step back as well a little bit here, because if I just touch upon the neighborhood health framework, it talks about how do we improve the coordination of the complex care, as you described, those with multiple conditions, multi-morbidity, multiple challenges. And in that scenario, and who provides continuity, so that they need continuity and coordination of care, and that continuity. And when I'm saying primary care team, that's not general practice. I'm being careful with my wording on there, because when it comes to that primary care team, which is the first contact, which is providing the coordination, which is providing the comprehensive care, as well as is the point of continuity, that can be general practice or community pharmacy, because we both agencies, and including the community teams and district nurses, or sometimes even the specialists, they can be that point of continuity. So if that is the case, at the same time, how do we improve access to primary care? Because some of those things may not need as much continuity, and they might be much better aligned with, and that shift is going to happen. The technology and the change is creating such a rapid change in that environment, especially all at the same time with now the qualification and the prescribing happening in community pharmacy. So to me, there are two different roles which are here. One, how is the profession itself, so the community, the clinical pharmacist skill set coming into the being,
Yeah.
and the opportunities for improving the person in the community's experience, how that is changing. And at the same time, what is happening, what can happen in the community pharmacy as a setting in that environment? Because till about 10 years ago, or before the PCNs, there were not as many clinical pharmacists working in general practice. Now we have a clinical pharmacist in variety of settings.
Yes.
And that gives an opportunity for us to be doing care very differently to how we would have done 10 years ago.
Yes.
So we can, where there is requirement for complexity, we can release people to focus on complexity, because there is an additional cohort of clinicians who can help manage that access side of things. And once we start bringing that skill set of complexity, if it's medicalized, and how do we optimize the care? Most of the time, the medical model relies on prescribing and medicines. How do we start doing structured medication reviews, optimizing the deprescribing, who's supporting with the concordance in that, what's happening with the care of the individual, who talks to the patient or the person receiving the care in terms of what they are for, and are they being able to take it, what's the problems? And if I was to imagine that without necessarily the boundaries of which silo they are sitting in, I can come to the thing of, yes, we need the pharmacist skill set. Now, the next question is, how do we make it into a reality of what the contracts actually allow us? What is the reality in this geography or this neighborhood? And then how do we make it happen? So that MD, or the neighborhood team might be a GP, a geriatrician, a social worker, a mental health practitioner, a community nurse, or a district nurse, or a care coordinator, or a therapist, and that's an occupational or a physical. All those roles come together. But then how do we work as an integrated neighborhood way of working? Not everybody will need to come into the meeting, but we still should be able to link with, and you brought in a point earlier on, Mike, that if the INT meeting knows that this person is getting delivery and now they are struggling with their medication because they can't, they need Dossets, but the pharmacist knows what's the problem happening on that side. And my terminology might be getting out of date, guys, so my apologies. So, but typical GP on that one. But where I'm going with this, because when I'm speaking to my own parents and they're saying, well, I'm trying to put my pills in my boxes and I'm trying to organize and I'm struggling with that and I forget whether I put that one in there and which color. The people who address it are the pharmacists. The medics don't have a clue on that one.
Yeah.
How? Well, I'm making another generalization. I'm probably going to get some medics upset with that. But now, but that's where the role comes in. So we're pretty clear on how different clinicians contribute in that. What we do need to understand is how do we get past those organizational or contractual silos to actually make it into a seamless thing? What are the local connections? How do things fit into that neighborhood?
Mm-hmm. And all the neighbourhoods are going to be different, Manik, aren't they? We can't have, one size fits all. There are going to be some nuances, aren't there? That's the other thing, to add a layer of complexity.
So each neighborhood is so different from one to the other. Whether that's from the mix of the people who live there and the characteristics of the people who are living there, but equally from the people who are providing services in that and the constitution of those services as well. So when you start putting that mix together, then how do you make that into a consistent experience? And yes, we are in Nottingham City, and I used to work in Clifton for a significant period of time of my life. And where Clifton used to be, we had 3 GP surgeries, we had a couple of 3 pharmacists, 2 dentists, and such. How we were organized or were able to do things in that patch is very different for what somebody is going to be able to do in Mapperley and the population needs. I used to joke on the patch that if you're working in Clifton, you need a passport to cross the Trent Bridge or the brook into Ruddington. So,
oh dear.
Brilliant.
True.
And that's where each neighborhood is going to have its distinction.
Yes.
And sometimes I don't want to call it patient groups, but our local volunteer groups, which I've had the luxury over the years of working with different small patient groups who are run as more voluntary sector. So whether that's in Meadows, there used to be a Meadows Association of Diabetics, and I still love them because I learned more about diabetes from them than from the courses that I did. The sickle cell group in again around St. Anne's, or the various groups in different areas, and how do we support them as a neighborhood health? Because they permeate far more. And we saw that during the pandemic. When it came to the vaccination and people were saying communities are hesitant, communities had questions.
Yeah.
And health professionals are not always connected with those things. So we saw with the black-led churches or within the mosques that working with the faith leaders. And how do we, as health professionals, health and care professionals, support them within reach?
I think to that point as well, Manik, with regards the sort of differences within neighbourhoods, I think for me, just as a layperson working with community pharmacy, the clue's in the name there, community pharmacy. Pharmacists and their pharmacy teams know their community, they know their patients, they could really help to inform how that could look on their patch, so to speak, because they know these people. They've known some of them for a long, long time. They know, if there are prevalences of, I don't know, frailty or whatever it might be, they can identify those cohorts of patients. I think Mike's scribbling something down there, and I know, Manik, you're going to come back on that. Go on.
So exactly, I think this is where it has to come into how do we tap into that continuity that community pharmacy provides.
Yes. Yep.
So without going into my own ailments and things, but I go to a small independent, and the chap knows the moment I walk into what am I normally talking about, and which vaccination I need, and what am I going to be eligible for. And the question doesn't start with who are you. The question starts with has anything changed from last time that we did this.
Absolutely. Yeah.
So, but that continuity doesn't necessarily always connect with the rest of the system's continuity.
Yes.
So
Yeah.
I have a continuity of relationships. If I was a patient or a person and a citizen or a client, and whichever way we go with this, so I have a continuity with my community pharmacist, I have a continuity with my GP, I have a continuity, but how do I bring them together? And that's going to be the crucial bit for us. That how do we bring along those relationships to simplify, and that's the magic which needs to happen.
Yeah, it is.
Yeah, and I love the fact that that's you know, those are the things that we can be working on now. Whatever the future's bringing, it really has to start with local relationships.
Absolutely, Mike. Yeah.
And local conversations, local understanding of what each other does. I mean, I remember, and this must be 10, 15 years ago, where there was a process in the PCT then, of walking in somebody else's shoes, which was massively helpful, because it meant that you were able to go and spend some time as a pharmacist with a GP and vice versa. And that local understanding, that local offer, that local insight into the stresses and strains and what somebody does on a day-to-day basis was incredibly helpful. And it was the start of fruitful conversations. Just a general relationship understanding led to more fruitful conversations. So that is the type of thing that we can be doing.
Absolutely, Mike.
Anyway,
to the question about, you know, what role do you see community pharmacy? There's one to start.
Absolutely.
You know,
absolutely.
and it's already happening, isn't it? It's already happening.
Yes.
And if it's not happening, there's an opportunity to start to look at that and feed that in. So,
and the thing, just building on that, and whichever reason, whether I say that there are times when the reports or the thought is not thinking of it's health or medicine centric, or whether the way the silos operate, or whether I say that's an action for me to let's try and contribute to breaking down those silos. So and let's have that agency to say, okay, the system is structurally such that it will often do these things and these mistakes. Let's have the agency to try and break those barriers or those silos. So how do I, and if I had to be giving one bit of a suggestion, because I don't like calling it advice and advice monsters come along, but one bit of a suggestion that I would make is reach out to what's happening in your PCN or neighborhood and in that service, in your GP surgery. Because like we have what we are doing in pharmacy first, and what's going to be changing with prescribing, and what the opportunities are. What can we do? And Mike, you have in the past asked about what can be shifted, who can provide that better care, and who can do what. And if we're going to shape that locally, those are some of the building blocks where things will be built from. So who are the predominant prescribers and people dealing with the question of one side is generating prescriptions and prescribing, and the other side is not just dispensing but handling, and sometimes now going to be prescribing. So let's the two sides come together and work out the solution. So let's see what comes from those every neighborhood. Let's speak to each other. Let's connect.
Yeah, have a conversation.
And what is interesting, I mean, there was a really good example of that, I think, is where one of our pharmacists in City, Deepak, actually collaborated with a couple of the surgeries in City to do the flu vaccinations for rough sleepers last November. And we weren't sure whether we can do it. And it's a point that Manik makes well about this, the individual silos, our own individual contracts, will they allow us to do things or not? And that even that understanding is helpful. But actually we got through that. It worked. We got a lot of learning. And suddenly, and I'm not saying this is all down to us and what we did, But suddenly the flu letter this year has changed, and now the flu vaccination program this year will include rough sleepers who can have their flu injection free of charge. And it's Manik's absolutely right. Starting small are the building blocks to getting bigger things, because
Yes.
it builds the relationships, it builds the trust, it builds the confidence. Oh, you can do what you say you were going to do.
Yes.
And you can, not only that, you can do it consistently. Great.
Yes.
Let's work on some other things then. So these small opportunities have only come from being ready to listen and being in a position to go, do you know what? I don't know what the answer is, but I think we're going to go away and find out.
Yes. Exactly that. Exactly that.
Yeah.
Is it, the other point I would add to that is, we often assume that the other side has got it perfect and there's a solution which is there. And coming back to Mike, your point of walking in each other's shoes.
Yes.
Yes.
And because when we do that, we realize the struggles on the other side as well.
Yes.
And when the other person says, yes, I said that we will try and do that and we can do that. But the reason why we are able to do that 80% of the time or the 90% of the time, because these are the limitations that we are working with.
Yes. Yes.
So how do we build that working relationship with each other to be able to mutually support? Because that's what will come in the collaboration space. That's what the joined up care will be. Because when we're going to join up the care, we are currently designed in a way that we are trying to bring the two things together, but they're not necessarily designed as a jigsaw piece which will click in each other. They are designed, and we'll need to shave off a little bit on this side and adjust a little bit on this side so that they actually click together.
Yes.
And that will only happen with understanding of each other.
Yes.
To what, not just what they can do, but what their limitations are. How can we actually do things differently? And that give and take will take dialogue. That will be the conversations we need to have.
Yes.
And maybe some work experience. Community pharmacists going and working in a GP practice and vice versa. And I don't know if that's a bit pie in the sky, but that would be quite interesting, wouldn't it?
Oh, definitely. So, Kirsten, this is the bit. This is
It's me with my marketing head on. Sorry.
No. So, I have, over the years, I've had the privilege of working in a GP surgery, having a short-term contract in acute, then working in an ambulance service, working in.
And it's opened your eyes, Manik, I imagine.
It changes your perspective.
Yes.
So I said to you earlier, and I still love the group, Meadows Association of Diabetics, just sitting down with them on a couple of weeks in the evening, just in that group, seeing diabetes from a very different lens, changes your perspective.
Yes. Yeah. Absolutely.
Yes, it does.
Absolutely. I could keep talking to both of you for a very long time, I feel. And I think you probably both feel the same way. I like to think so anyway. And I think this is an important point to make. This is just the first exploration, and I think we've been joking about a box set, but Manik, this is the second time we've spent some time with you, and I like to think that this is something that we can do on a regular basis, because things will change. But I think, as Mike said, and you both said, it's small steps. We can't rush headlong into anything. It has to be collaborative. There's so much going on, and I think, as Mike said at the beginning, the work that you've done so far is just phenomenal, and a lot of learning to be had from that. And I know you asked our committee members for some feedback when you came to see us do the week, which hopefully was very beneficial, and that's something that we could maybe talk about through next time. But I think I'm probably going to close it there, unless anybody wants to add anything, because I think we've talked about a lot of stuff. And I would also like to say to contractors, anybody listening, pharmacy technicians. If you have any questions about this or suggestions or ideas, or you want to do that work experience in your GP practice or in your dentist or your optom, let us know. Let's see if we can facilitate. I don't know. There's got to be, we have to head this collaborative working, and together it has to happen together. We need to have these conversations. We need to have that dialogue. And here at Community Pharmacy Nottinghamshire, I know, Mike, you'll agree with this, we're open to that. And if we can facilitate that, we will do so. So we're here, the door is open, and I'll pop contact details on. Anything to add, gentlemen, before we close?
Kirsten, I agree. This is a start, and I think that I haven't gone into the full frameworks and the guidance as such, because they're available for everybody to read. But
yes, we'll pop those on the website, Manik. Actually, yeah.
So, but at the same time, this whole thing is about, if we have to start improving the joined-up care, we have to start building relationships, and we have to start working. We have to have a shared understanding of what each other can do. Yes. And while we will be building the integrated neighbourhood teams and the MDT meeting, which will happen, it is much more about the neighbourhood way of working, where we are all aware of how do we work together. And that will only build over a period of time. So I'm glad to be here. Absolutely. If I can learn from you guys and share more back as well and contribute, more than happy to in future as well. So definitely look forward to that.
Fantastic. You're welcome anytime, Manik. I think we said that, and I'm sure Mike will agree. Mike's
absolutely.
Nodding.
Yeah, absolutely. Yeah. It's no good just nodding, is it, when you're doing a podcast?
No, it's not, sadly, when it's a podcast. I'm conscious of
that. But no, I agree completely with what Manik has said, and just underline this point about this is a starting point. But what I would encourage all of the listeners to do is have their ears open and their eyes up, so that they can see things differently, they can hear things differently. And when that happens, phone us to have a conversation about the opportunities that they see and hear.
Exactly, Mike. Yeah. Because
one of the things that my role does, it actually concentrates all of the things. I know what's going on around Nottinghamshire. So I know what's working, I know what hasn't worked, I know the things that we've already done. So therefore, it gives me confidence that there are more opportunities out there than we probably understand, and certainly can't see at the minute because of, well, we just can't see it because we're not working in that way.
Yes. That different perspective, as Manik said, isn't it?
Exactly. But it's exciting. I think we have to be confident in who we are and what we already deliver as pharmacists, because we know there are some brilliant examples, brilliant relationships of pharmacists around Nottinghamshire working so well with their GPs already. And probably there are some models that I haven't found out yet, just there, but it's already working. So this isn't we're not changing everything. That's not the point. But the point is how do we consistently work differently going forward?
Yeah.
For the benefit of the patients.
Of course. Yes, of course. Right, fantastic. I am going to leave it there. Thank you both very much.
Thank you,
really
Manik.
Appreciate it. And I look forward to catching up with both of you again very, very soon. Thank you, everybody, for listening. And if you have any questions, I will put some emails at the end of this podcast. And obviously, you can visit the Community Pharmacy Nottinghamshire website whenever you wish. We'll pop that framework on there that Manik mentioned. It's really interesting, actually. So we'll get that popped on there. So, yeah, thank you, everybody. And we'll hear and listen to you very soon. Take care. Bye-bye.
Thank you. Bye.
Thank you.